I'm Anthony Leeds. It's my pleasure to welcome you again to another episode. And this time we're going to actually look at the question of dementia. And I'm going to be joined in a moment by Dr Nolan from Waterford in Ireland. And we're going to continue the discussion that was started last week when we were looking at the role of carotenoids in relation to retinal health and eye health. But with regard to dementia, many people, of course, are aware that with aging populations around the world, the prevalence of dementia will rise. Most studies and most epidemiological studies on dementia have been undertaken in European populations, and populations from low and middle income countries have not yet really been studied in terms of the prevalence and the likely increase. We know for the United Kingdom that the numbers are quite likely to rise to 1.4 million even within the next 6 years. So it's going to present a tremendous pressure on healthcare services and also on social care services. So this is a very important issue for Western European countries, North American countries, but also will increasingly be a problem for other countries around the world, including those in South Asia. So Dr Nolan, welcome again. Thank you very much. We're going to continue the discussion that we had last week. So may I please ask you to begin and explain how the work that you've done in relation to the eye is relevant to the brain?
Thank you, Dr. Leeds, and thank you for the opportunity to continue our discussion, to expand upon our last episode where we had the valuable discussion around how these particular nutrients called carotenoids are playing a localized and active role to support eye health. And I never imagined that I would be speaking or doing research related to neurodegenerative diseases. But here we are, but there's an absolute reason for that. And the first reason is we shouldn't be surprised by it. Our work for over 2 decades on the retina, which is that film at the back of the eye, that sensitive tissue that captures all the light and allows us to have the beautiful sensation of vision. I mean, the retina is part of the central nervous system, so it's essentially the seeing part of the brain. So by extension, everything we've been able to learn about how we can use nutrition enrichment for eye health and eye function extends at least to what we've learned in the brain. And there was a couple of key experiments that has kind of led us to this point, and some happened in parallel. Over 10 years ago, a scientist in the US, Professor Liz Johnson, has studied brain health and brain function in a centenarian study. This is a professor from Tufts University in the US. And Professor Johnson very nicely demonstrated in her works that the nutrients that I had been looking at in the back of the eye, these carotenoid pigments, are also found in the human brain. So essentially, when they analysed human brains, they were able to identify, detect and measure carotenoids present. But what was truly fascinating about that centenarian study was that Dr. Johnson and her team had measured the macular pigments, these pigments that I speak to, in the eye in the living person. And then post-mortemly, when they analysed the brain for carotenoid concentration, they demonstrated very clearly that the amount of these macular pigments, these carotenoid pigments in the eye, were highly correlated with the amount in the brain. So here we see for the first time, we have a biomarker for brain nutrition in the living person. So when we in our studies measured macular pigment, it was an indicator of the amount in the brain. Now, around the same time, I was very fortunate to work as part of the Irish longitudinal study on aging. This is known as the TILDA study out of Trinity University in the Republic of Ireland. And the professor on that program was Professor Roseanne Kenny. And I was responsible in that initial experiment for measuring the macular pigments in over 5,000 people in the Republic of Ireland. And this was a very unique sample, a very rich sample in science, because it was a random sample from the Irish population of adults over the age of 50 years of age. And what we discovered in our works were that the macular pigments, which we measured in all of those participants, were highly correlated with cognitive function. So extending from Professor Johnson's work, knowing that the pigments are an indicator of the brain amounts of those nutrients, we added a layer of information to that which demonstrated that individuals with high macular pigment scores have significantly better brain function, cognitive function, attention, episodic memory, reaction time, all these parameters of brain function that essentially make us what we are, were related. Now, as you know, Tony, we call this type of research observational in nature. So it was an observation, a cross-section, if you like, of the population. And it was just fascinating to see the strength of the data. And all of these works are now published, of course, in top brain journals, which you'll be able to see on my own website. So that initial kind of serendipitous bunch of experiments really focused our thought process into the study of carotenoids for brain health and brain function. And I collaborated very successfully with Professor Rihanna Mulcahy, who's a professor here in the southeast region of Ireland in University Hospital Waterford. And Professor Mulcahy on a daily basis works with patients with neurodegenerative diseases, dementias, predominantly Alzheimer's disease. So she was very supportive and very interested in our research into carotenoids, and we decided to do an experiment. And the first experiment we did was to measure carotenoids in patients with established Alzheimer's disease. And in that initial experiment, which is also published now, we showed that individuals with Alzheimer's disease have a major deficiency in carotenoids. And we may not have been surprised by this because, you know, one of the issues or the challenges of dementia and particularly Alzheimer's is these wonderful patients, unfortunately, lose their appetite, so they stop consuming food. So our knowledge that these carotenoids are entirely of dietary origin would speak to that discovery. But then we had to see if we were to give them carotenoids, would they be able to respond? So in other words, we wanted to see if the issues that they were dealing with in terms of a lack of carotenoids were due to the fact that they were just not consuming the dietary plant pigments, which we spoke about in the last episode. And what we discovered in the initial exploratory interventional trials, these are the CARDS trials, were that the patients responded brilliantly well. So it wasn't that their biology, their internal biology, didn't allow them accumulate, transport, and deposit carotenoids in the eye and the brain. It was simply that they weren't doing it. So then we wanted to see if that was of any benefit to their, if you like, cognitive function, their quality of life. And we ran these experiments, for full disclosure, as kind of single blind experiments. So they were not that top layer gold standard trial yet, because we were learning about how to work with these patients, how we could measure brain function, and how we could do all of that. And in the first experiments where we just used carotenoids, we found that an improvement in the vision, similar to what we'd seen in patients with AMD, macular degeneration, and in the healthy population, but we had no impact at all at that point on their cognitive abilities or their brain health and function, if you like. So we continued our research and we studied the brain further. And of course, these nutrients, one thing we learn with nutrients in biology is they work what we call synergistically. And that means that they can help each other do the job they're supposed to do. But our clear study of the brain was fascinating because what you learn very quickly with brain disease such as Alzheimer's is the disease is actually resulting with a shrinking. The brain shrinks. And this is where a lot of the problems start. So then you have to understand, well, what are the components that make up the brain? What are the molecules? What are the structures? And we see that the brain is a very fatty organ. We see that it's predominantly fat, in fact. And then when you study the type of fat and fatty acids that are present in the brain, we see that there's this compound called DHA, which is part of the omega-3 fatty acids, which is highly concentrated in the brain. So we felt it was very interesting at that point to combine our carotenoids, which we know have antioxidant, anti-inflammatory benefits, to a carrier that was high in DHA, so an omega-3 fatty acid. And we did this course at the university here in Waterford, and with support from the Herd Foundation UK, and Dr Alan Herd worked with me on these experiments, the late Dr Alan Herd, and we saw really fantastic outputs early on with these experiments. And we started to see, Dr Leeds, a very clear pattern of improvement in quality of life, again in this single blind study. So we got very interested and excited about all of this, and we published this work, and there was a very clear message back to us at that point was, look, this is well and good, but the strength of the study design could be improved upon. All of these scientific critiques and media critiques we accepted. So we then said, let's design our REMIND trial, which was the memory intervention with nutrition for dementia. So we ran a very good, well-designed, double-blind, placebo-controlled trial called REMIND. So Professor Mulcahy and myself and our research team worked on that trial for many, many years. And it was a 24-month interventional trial. We recruited circa 80 participants who had, this is a very important piece of information, they had established Alzheimer's disease, so it was early to moderate, but these participants for the trial were only included based on an expert panel that were involved in the full diagnosis. So it wasn't just that they had the symptoms of Alzheimer's disease. We had to look at all of the parameters. And one key factor of it was that they had to have what we call progressive Alzheimer's disease. So it was a disease that was in its early stage, but it was progressing. Because the whole concept here of using an omega carrier, which finds its way to the brain to deliver these very valuable carotenoid micronutrients, would be that we could not even, we never suggested or felt that we were going to stop the disease or change that, but we felt that we could have, with early intervention, be used to support the management of this condition. Because these diseases are there. The biggest challenge with these diseases relates to the patient's quality of life. And we see this really clearly with Alzheimer's disease. The patient loses themselves, the family member loses their parent or their loved one. You know, it becomes a disease which I like to put as a disease that's very, very frustrating for the patient and their family. Professor Mulcahy describes it as a scenario whereby it becomes problematic and it changes their mood because they can see the words or they can see the people, but they just can't connect the dots. So their whole brain network breaks down and their ability to function in that way becomes highly compromised. So in our REMIND trial, we measured the response to the intervention with, this was the carotenoids, omega-3 fatty acids, and we also had vitamin E, which is another powerful antioxidant of the brain. And compared to placebo, we saw very clearly, Tony, improvements, of course, in the biology markers, in the blood, skin, all these parameters of carotenoids, which were crucially important. So we saw this wonderful response in all these patients. And when we looked at all the parameters of Alzheimer's disease, Professor Mulcahy's approach to this with me was to look at what we call the patient's story. This is called clinical collateral. So it's not just measuring what a classic MEMSI score, which you see routinely done in clinic. It's putting the whole package together. And long story short, based on a collateral assessment informed by the primary carer, we saw wonderful improvements in a significant percentage of patients who were on the active group in terms of changing their memory, in terms of reports back on how their quality of life and mood improved. So they still had the disease, but they got to function much better and live with the disease much better. So by extension, Dr. Leeds, looking back to all of our other works where we've done this, by the way, we've conducted in our CREST cognitive function studies a program whereby for you and for me and for a majority of your listeners to your show, we demonstrate benefits in enriching these carotenoids. The point being here, yes, prevention is key, early intervention is key, but I like to suggest that the benefits of these nutrients are from the cradle to the dance floor. And the reason why I say that, Tony, because, you know, the whole concept here is that these nutrients are allowing us deal with the cost of living, which is this whole process which I explained last episode called oxidative stress, and that's simply just as our cells are replacing themselves or as they're working, they're vulnerable to this byproduct of oxygen metabolism, which is called oxidative stress. And remember, a developing eye and developing brain has so much oxidative stress; it's a problem.
What was the reaction to the publication of that, and to what extent has it been taken into practice? And then the other question, of course, is do you now have to go and do a much longer term study?
Oh, two very good questions. So thank you. The reaction within our own community was, our scientific community was extremely positive. And I'll come to the clinic reaction in a second, but the scientific reaction was quite positive. In fact, the editor of the Journal of Alzheimer's Disease wrote to me personally. Professor George Perry, who's the most cited scientist in Alzheimer's disease, is a massive supporter of this work and what we've done. And the reason being is that if you look at all the other science that's been conducted in neurodegenerative disease, everybody's looking for a silver bullet. Everybody's looking for a cure, you know, trying to fix these plaques and tangles, these unwanted kind of structures, protein structures that we are able to see present with the disease. And we know that the current treatment regimes although media has had a lot of excitement, when you look under the bonnet and when you look at actually the data and when you look at how it's being used, there's no real treatment for Alzheimer's disease. We know that. In terms of what we've done, it always becomes, to a degree, questionable and criticised by, I suppose, clinical profession. And the reason for that is the size of the study, maybe. They want multi-centred, they want longitudinal follow-up. But the challenge to that, Dr. Leeds, is we don't have billions of dollars to run that experiment. I'm highly confident that if we did, we would be able to demonstrate that. But for me, the fact that we could demonstrate all these wonderful outputs and demonstrate that these targeted nutrients have a role to play in the co-management of this condition is something we should celebrate.
Yeah. Now, one of the other interesting things, and you and I have discussed this already, is on other occasions, is that obviously as antioxidant compounds, there's a potential application in cardiovascular disease. And of course, cardiovascular disease does contribute to some forms of dementia. And so and indeed, of course, there is cardiovascular disease elsewhere in the body. To what extent do you think we should start to look carefully at the role of these compounds in causation and possibly, when treated, prevention of vascular disease? And what work needs to be done? That's a vast set of questions there. But
no, but it's a very timely question, as always, by you, Dr. Leeds. Your scholarly knowledge on this is wonderful. So I love having this discussion with you. I think what I can tell you and your viewers and your listeners is that we're already there in terms of our study. We actually have a paper coming out in the next few weeks. I worked with a scientist, Dr. Nicole Stringham, and Dr. Marina Green, a medical doctor, Dr. Green, and Dr. Nicole Stringham. Her primary research area is measures of inflammation. And I believe that all sickness comes from oxidative stress, including sickness of the vascular system. So for example, in our most recent publication, we can measure markers of inflammation, which is quite standard in medicine and science. So if the scientists listening, they'll know TNF-alpha, IL-1 beta, or IL-1 beta. But if we look downstream from that, there's something that causes those inflammatory responses. And in the vascular system, that is what happens is we have LDL, so these unwanted LDL or excessive LDL can become oxidized. And if that LDL becomes oxidized, which it typically does when we're alive, if you like, if our ability to kind of clean that mess up, and so what happens is we have LDL, which is part of that kind of cholesterol profile that we don't want to have excessive amounts of. If we have that and we have too much of it and it becomes oxidized, the macrophages, so this cleaning system which the body has, becomes compromised, because what happens is the LDLs become oxidized, and it creates what we call a foam cell, which is like a puff cell, and the ability of the cleaning system, if you like, is compromised, and we can't remove it. And what happens? The body says, oh, I'm in trouble here, and it calcifies over it and creates this is what plaque is. So as we become unhealthy, even in a minute way, we are starting to develop these kind of plaques. And I believe it's the exact same process that happens in the brain. And what we've shown in this new experiment is that the carotenoids and omega-3 fatty acids are wonderful at reducing the oxidized LDL. So we can move downstream and have a positive intervention early on.
Just to go back to something that you commented on previously, which is you said there's no treatment. Of course, there has very recently been introduction of two medications which have known mechanisms and which do seem to be promising in the short term, and which physicians in the United States particularly are going to look at in terms of beginning treatment earlier. And I think there are global studies taking place in that area. So given time, there may well be the potential for some pharmacological intervention, but as you're quite rightly pointing out, it may well be better to even look at the underlying mechanisms, which of course there's going to be genetic elements in the disease, both vascular disease and also dementia. And of course there are many types of dementia as well where different processes are taking place. So it's a little bit sort of complicated, isn't it, in terms of where we are and what we can do next and what we should do. One of the key things, though, what viewers are going to be asking now is, well, what's the relevance of this to me? If they have a relative who is known to be moving in the direction of developing dementia, they will be aware that memory loss and all those problems with language, finding the right word, confusion about time and place, all those early features which begin to suggest this, bearing in mind also that in some countries the recognition of dementia as a condition is not as strong as it is in Western countries. What can these people do in terms of ordinary diet and lifestyle? Sitting here now, what do we know from the epidemiology? We can say there's an association with, for example, smoking, obesity, diabetes, high blood pressure. You get all those things correct, stop smoking, look at your diet in general terms. What would you say to them now based on what we know? Obviously, that those medications that we mentioned earlier, of course, they're fantastic things that have been developed, but the cost per annum of treating an individual with those is phenomenally expensive and isn't going to be able to be replicated across the globe when you consider the numbers.
Not at all. And look, nothing I'm saying here today on this episode or on the previous episode is meant to suggest that our discoveries with nutrition and nutritional intervention and supplements is to replace any medicine-based treatment. That's not the point of what I'm speaking about. But I'd like to answer your question in terms of what does this mean for society, essentially, is what your question is, and what could we do? So I'll come to that. But I'd like to kind of make one comment before I get there, and that is, you know, in terms of the pharmaceutical agents and the billions of dollars that have been spent on pharma for Alzheimer's disease particularly, I mean, the facts are, you've already answered one of them, they're not affordable, they're so expensive, but also they're not being used. You know, here in the Republic of Ireland, for example, I presented at the annual geriatrician meeting this year, and there was a whole session on the new drugs, pharmaceutical agent, and, you know, not one single doctor had access or will have access to in the short term using those agents. And I'm not saying that even if they do work, that we should forget about that and just concentrate on nutrition. Not at all. I think there's room, that's why I use the word co-management. But in terms of the pharmaceutical piece, we must also be alerted to the very clear data that shows the issues and the safety concerns for lots of patients on that. So that's just something I'd like to acknowledge. But in terms of what patients can do, I really like this question because I actually had a discussion today with someone about this, and the suggestion that was put to me was, well, you know, we love what you're doing, Professor Nolan, and, you know, the evidence is very clear, but should we not just recommend a Mediterranean diet and, as you say, stop smoking? Of course we should. We should do all of that. However, the point is, complying to a Mediterranean diet across the world at the level that we would need to give us the outputs and the protection that we now need. Because remember, Tony, the reason why we're having this conversation at all is because we're living way too long. That the celebration of aging has presented the challenge of function and health as we age. So it makes absolute sense to me that we do something in an interventional capacity to counteract what good medicine and good lifestyle and good science has positively changed. Because I don't want to be old and have no function. I'll celebrate aging when I can still connect with my family or still have a quality of life. In terms of what people can do, what they can do is understand the type of healthy foods that deliver carotenoids. And we know what these are. They're the leafy greens, spinach, kale, anything with natural color typically has carotenoids. Eggs are wonderful food factories that deliver carotenoids. I'm a big supporter of eggs, and I have no issue with cholesterol. I think cholesterol is essential for life, but it's understanding the type of cholesterol that we want to have and optimizing that, as you know better than me. So eggs are great, I think, with carotenoids, because the bioavailability of these carotenoids is truly valuable. But as I said to the individual today, if you were to ask me to summarize quickly what are the discoveries of our time, and they're essentially that we have identified what's good in the Mediterranean diet, what's good in plant-based nutrition, and in a safe way, we've been able to extract those exact micronutrients that are stored in the eye and the brain and deliver those benefits. And knowing that these have been studied and knowing that these are safe for consumption, why would we not do that across the ages, from the cradle to the dance floor?
Yeah. Well, I'm of course convinced that you're absolutely right, but we have to explore those other issues as well. Just before we finish, let me just remind everybody that underneath the window that contains this video, there will be some notes and some web links to other sources, so you would be able to find out much more. But perhaps we should just conclude, and if I were to say to you, as I often do when I'm talking to people, if you were able to gain the level of funding that is you would ideally like, £5–10 million or something like that, what would you want to do next in order to take you to a stronger position in terms of advocating the use of these carotenoids for use in dementia? What would be the next thing that you would like to do?
Thank you. I would make sure that I had access to the nutrients that we've studied that have a quality approval, a supplement certified approval, so that we know that they're a very good supplement. And I would like to strategically run massive multi-centered trials with scientists and doctors from every part of the world. We would have to design our research questions specific to those populations. And I would focus it on that earlier intervention, not necessarily even with people with established disease. I would like to run major longitudinal work, which is highly, highly expensive to do. But I have an idea around that. But, you know, I've been very lucky in my research, Tony, to secure funding from the government and from the Howard Foundation and others to do this, but the level we need to go to kind of replicate this. But I'm convinced with the data we have now, it's time to implement the science and shorten the time whereby we use the science into medical practice safely.
Yeah. Well, I'm sure you're absolutely right. So, John Nolan in Waterford in Ireland, thank you very much for joining us and talking us today, and I look forward to talking to you again in the future when we perhaps have a little bit more to tell people. But for the moment, I think we're in a very strong position. So well done on everything that's been done with by you and your team over the last 20 years. It's absolutely brilliant. As you know, I've been following carefully for several years anyway. So well done, and thank you very much for joining us. Thank you.
Thank you, Tony. God bless. Thank you for the opportunity.
Thank you.